art and science, as well as dramatic, musical, and literary performances. And all events are free to the public and are held at the Concord City Auditorium. We encourage you to check out their website at walkerlecture.org to view their calendar of programs. We have a wonderful program for you today. What's Up Doc is pleased to welcome Dr. Kristofer Roberts and oncology nurse navigators Caitlin Roberts and Kim Pauliks from Concord Hospital's Payson Center for Cancer Care. They will guide us through navigating a cancer diagnosis. I want to share a little bit about our presenters with you. Originally from Alaska, Dr. Kristofer Roberts received a Bachelor of Science degree and a Bachelor of Arts degree from the University of California, Los Angeles. He subsequently conducted neuroscience research at the Semel Institute for Neuroscience and Human Behavior at UCLA, where he studied the reward system and Parkinson's disease. Dr. Roberts matriculated to the David Geffen School of Medicine at UCLA, and he graduated from there in 2015. Dr. Roberts completed his residency training in radiation oncology at the Mayo Clinic in Rochester, Minnesota, where he had the opportunity to serve as chief resident. Dr. Roberts joined the Concord Hospital in August of 2020. Dr. Roberts has numerous publications in both neuroscience and radiation oncology, investigating topics such as prostate cancer, breast cancer, and biologic modeling in intensity modulated proton therapy. A member of the Symptom Intervention Committee in the Alliance for Clinical Trials in Oncology, Dr. Roberts remains actively involved in research and is currently co-chair of a multi-institutional phase 3 clinical trial. Joining Dr. Roberts today is Caitlin Roberts, oncology certified nurse who has been with Concord Hospital for 10 years, working in both the inpatient and outpatient settings. Caitlin has been in the role of oncology nurse navigator for the past 5 years and supports patients diagnosed with esophageal cancer and head and neck cancer. When she's not working, Caitlin enjoys spending time with family and friends, reading and cooking. Also joining us is Kim Pauliks, who has been a nurse for 15 years, and she has spent all of these 15 years here at Concord Hospital. Kim's background is in inpatient medical oncology, where she cared for patients with all types of cancer, and she administered chemotherapy. For the last 2.5 years, Kim's role has changed to that of oncology nurse navigator. She now helps support patients diagnosed with lung cancer. When she is not working, Kim enjoys time with her husband, her 2 boys, cooking and gardening. Please join me in welcoming our speakers.
Good afternoon. Thank you for this opportunity and for inviting me here. The title of the talk is Navigating a Cancer Diagnosis, which we'll learn more about navigation in the setting of clinical cancer care, and both Caitlin and Kim will fill us in more about that. But as a radiation oncologist, I also wanted to give a brief overview of the role of radiation therapy in cancer care, discuss a few points of expansion in the field of radiation oncology. We'll touch upon the complex both patient experience in cancer care as well as on the provider side. And then we'll touch on a couple patient experiences and then focus on the importance of nurse navigators in cancer care. So every year the American Cancer Society puts out statistics and figures on cancer, and I think everyone is fully aware of the difficulties in cancer care and the prevalence of cancer. This is the projected numbers of cancer cases across the United States. This excludes very common things like squamous cell cancers of the skin and basal cell cancers of the skin. But for 2022, New Hampshire has about 9,500 projected cases of newly diagnosed cancer. These statistics are relatively stable from year to year in recent years. At the top, I don't know if you can appreciate all the numbers, but essentially at the top are the estimated new cases of cancer annually. At the bottom are the estimated deaths. Prostate and breast still remain the most common cancers in men and women, but for both, lung cancer are the leading cause of death in cancer. And I should say that radiation actually has a role in everything listed here. It's more limited in things like leukemias, but we still are involved in transplant protocols. So radiation therapy is delivered in a couple different ways. The most common type of radiation therapy is called external beam radiation therapy, or EBRT. There's a lot of acronyms which you'll see throughout the talk. And that's essentially delivering most commonly high-energy X-rays from outside to inside. Those X-rays pass straight through the patient, and we've had quite a number of advances in recent decades with increased computing power. Historically, we still do use three-dimensional conformal radiation therapy. That's a technique that came about with the advent of the CT scanner. IMRT is a more advanced delivery technique that we use commonly, where we can modulate the intensity of the beam and it gives us better plans. There's something called VMAT, or volumetric modulated arc therapy, and that's where the machine rotates around the patient entirely and can modulate the intensity and shape of the beam as it travels. It's very common these days that we use image guidance. We have the ability to get CT scans every day to target things properly. Now there are advances in MRI-guided therapy in some institutions. Stereotactic radiotherapy is one of the more advanced techniques which we do have here. It basically means we're taking a conventionally fractionated, which means historically we would give one treatment per day for 5 days a week for up to 9 weeks. And the concern was always that delivering it too quickly would cause too many side effects. But with the computers nowadays and the technology we have, we're able to deliver very high doses of what we call ablative radiation therapy in a very short amount of time. So that's what SBRT and SRS are, where we can treat in anywhere from one fraction or one treatment to 5 treatments. And the SRS in particular is about treating the central nervous system most commonly. And that's where we can deliver a single dose of very high dose radiation therapy to the brain. Particle beam therapy is also under the category of external beam radiation. The most common type of particle beam therapy that people are familiar with is proton therapy. It's different than the X-rays that just pass straight through the body. The particles are given a specific energy to go to a certain depth and traverse specific tissues. The big advantage is that there's no exit dose, so that where they stop, they dump most of their energy. The challenges are not small with particle beam therapy. It's exceedingly expensive, and it's very, very physics heavy in terms of delivering treatment safely. So that's pretty limited to large academic institutions. The other type of radiation therapy that has been around for the longest actually is brachytherapy, and that's the use of radiation sources to deliver radiation therapy from the inside out. People may be most familiar with prostate seeds, which are radioactive seeds implanted in the prostate that are permanent, and they deliver radiation therapy slowly as that radiation is typically from the iodine-125. That radiation therapy slowly comes out and treats the surrounding tissues. We have something that's more recent called high-dose rate brachytherapy, where it's a much more radiation-heavy source that's used, and it's temporarily implanted in the patient. So the patient is taken to the operating room, there are catheters put in place, and essentially a robot puts the radiation source in various spots throughout the tumor to deliver the radiation, and then it retracts back into the robot. The purpose of this is to deliver very high doses of radiation therapy. We can deliver higher doses with this method than we can from the external beam method. The challenges are that there's anesthesia, infection, bleeding, and procedural risks that we don't have with the external beam radiation. I mentioned the acronyms. There are a lot of different acronyms in radiation therapy. This just gives you an an example of several of them. In terms of the biologic basis for radiation therapy, in one sense it's rather simple, in another sense it's quite complex when it gets into the interface with the immune system. But essentially what radiation is doing is it's causing DNA damage to the cancer cells. And the goal is to damage them to the point that they can't survive, that they die. Both normal tissues and cancer cells are exposed to the harmful effects of radiation. And what the treatment paradigms are developed to exploit the differences in DNA repair. So the cancer cells are not very good at repairing their DNA when it's damaged, whereas the normal cells can repair much of that damage as long as you have about 6 hours between treatments, which is why we tend to deliver them daily. And the conventional track of treating patients for many weeks allows the DNA damage to build up in the cancer cells while its continuing repair goes on in the normal tissues. So exploiting that difference allows us to ideally keep the toxicity as low as possible while still killing the cancer. All tissues of the body have different thresholds for radiation dose, and that's something we pay very close attention to. In our treatment planning process, we have to both deliver the dose that's sufficient to kill the cancer while at the same time keeping the toxicities or those thresholds in place to avoid causing too many toxicities. Over 100 years ago, the brachytherapy was actually in clinical use. The early sources were radium, and the field's developed since that time. Cobalt teletherapy came along in the 1950s. That was used and is still used today for external beam treatments, largely in the developing world. And in the developed world, there's something called gamma knife, which people might have heard of. It's a cobalt therapy source that's very pinpoint for brain metastases. So it still is used in treatments these days. Proton therapy was actually developed in the 60s, and it's since that time become much more advanced. And then as we get into the 2000s, the techniques we use most commonly these days, the IMRT and the VMAT, have all been relatively recent advances. And at the bottom, the intensity modulated proton therapy is the most advanced proton therapy technique we have these days. Again, the goals are to prevent regrowth of the tumor, reduce tumor size, while at the same time balancing acute toxicities, meaning symptoms patients might experience from the radiation during treatment, and also reduce the late effects or long-term toxicities. So external beam radiation is delivered using a LINAC, is what we call it. It's a linear accelerator that generates the high-energy X-rays. This is the machine we have here, and we're actually getting a second one in the coming year. And the patient just lays on this table while the machine rotates around. So as long as the patient's only job really is to lay still, and the rest of the work is done by the machine and the therapists. In the early days before the advent of CT scanners, we were dependent on 2D X-rays, 2D films. So the old types of radiation therapy, we would get an X-ray and basically design a beam path, and that would be it. So this patient would have a radiation treatment, and the beam would go straight through the patient, rather simple. With 3D planning, we were able to model that more effectively on a 3D scale, so it really helped constrain the dose. And this gives you an appreciation for the different techniques. It's basically a heat map of the radiation delivered. The red would be the hottest, the blue is the coolest. And the upper left panel is 3D CRT. That's that older technology where we would call this a 4-field box, essentially 4 beams at the area where they cross as the area of the high dose treatment. The IMRT, or that intensity modulated radiation therapy, allowed us to carve the dose more effectively. The one we use commonly these days is VMAT, where the machine is rotating around, and as you can see, it delivers a little bit of radiation to the entirety of the patient. But the very low doses we don't worry much about. But it allows us to really constrain the high dose treatments, and it's actually a pretty quick treatment too, which is important. On the lower left is passive scatter proton therapy. Intensity modulated proton therapy is in the middle. The big advantage of protons, with the exception of a very few numbers of cancers that are more effectively treated with particle beam, the big advantage in general is not thought to be cancer control. It's the avoidance of radiation to non-target tissues. So as you can see, there is still some entrance dose, but the area that the beams don't travel through gets no dose. And so that over time has really proven itself primarily for pediatric patients. There's a very small risk of actually causing cancers from radiation exposure, which has become apparent in studying children who've received radiation therapy. So the proton therapy is most widely used in pediatric populations. And then on the bottom right, you can appreciate how tightly conformal the brachytherapy is. So this is a brachytherapy plan where it really allows us to limit the dose most effectively. Stereotactic radiosurgery is the advanced technique that we use most commonly in the brain to treat brain metastases. The alternative method is neurosurgery, and sometimes we use them both in conjunction. So what you see here on your left, this white spot would be a brain metastasis, and around it it's a little bit darker, and that's the area of edema or swelling. We can create a VMAT plan where it's delivering these arcs and giving radiation therapy from different arc angles that allows for a very tight radiation plan. And on the far right is the prescription dose, and that's delivered in a single treatment. It's typically delivered in under 2 minutes and probably about 15 minutes for the patient on the table. Our image guidance has drastically improved over the past few decades. We use mini CT scans often to localize our treatments on a daily basis. And it allows us to see the three-dimensional anatomy, which can change from day to day, so it allows us to make sure we're on target. It also enables us to reduce our margins around the tumor itself to decrease the risk of toxicity. A second technique, which we also have here, is called optical surface mapping, where we can monitor the surface of the patient with sub-millimeter accuracy in real time. And we can set thresholds so that if the patient needs to be in a very specific position, if they're holding their breath, or we want to make sure that the beam cuts off if there's any movement, we can set the thresholds and the radiation will immediately stop if the patient exceeds those thresholds. So this has been a relatively recent advance. So radiation planning, a patient would be referred to the radiation department. They come and see us. We talk through their case and decide if the patient would benefit from radiation and what that would look like in terms of the treatment recommendations. If they do need radiation therapy, we have to do a planning session where we basically set that patient up with different techniques to immobilize the patient, which basically means we want to be able to set that patient up in the exact same position every day for as long as her treatment is prescribed. And then we get a CT scan in that position we use for treatment planning, and sometimes an MRI as well. And that whole process, the consultation is usually on a separate day, but it's about a half a day for the first 3. Contouring is where the doctor decides what needs to be treated on the tumor side, and also we contour out any adjacent organs at risk, we call them. So non-target tissues that will get some exposure to radiation therapy. And then we send it to our dosimetry team who work with the computer programs to ideally satisfy every parameter given. It's always an iterative process, which can take up to 2 weeks in really complex plans. And then we have a group of physicists who work to QA every plan we have and make sure that the machines are within tolerance. So this is one example of some of the structures. This is a brain treatment. And this structure here, if you can see the mouse that's purplish pink, would be our target tissue that we'd be treating with radiation therapy. And here we have the lenses, the eyes, the retinas, the optic nerves, the optic chiasm, the brainstem, the hippocampi. So all of these other structures have strict dose tolerance limits. And so the plans are generated by ideally satisfying dose delivered to the tumor and dose spared to structures like the optic chiasm and brainstem. This is a heat map again of a plan for this patient. We use this analysis tool called the dose volume histogram, where we're looking at doses to all of these different structures to come up with the most optimal plan. The classic indications for radiation therapy are twofold. One is as part of a curative or definitive treatment. So if a patient is diagnosed with a localized cancer, It may be radiation alone, it may be radiation delivered before surgery, it may be radiation after surgery, it may be radiation with or without chemotherapy or immunotherapy. But the whole goal is to wipe out the cancer. It's a curative intent treatment. The second role of radiation therapy is in patients who do not have a curative option, and if they have progressive cancer that can cause pain and other symptoms, that radiation therapy is actually rather good at treating. So if a patient has a painful metastasis, we can treat that with radiation therapy, typically more quickly than the longer courses of treatment, and the doses are lower, so the side effect profile's lower. And it tends to work quite well for, in particular, cancer-related pain. Radiation therapy is considered a local therapy, so it's more akin to surgery than it is chemotherapy or immunotherapy. Those are considered systemic therapies, meaning they go through the whole system. And so radiation therapy really only works where you aim the beam. It's not that simple in actuality, and there's a very exciting array of research into this question, is how the immune system interfaces with radiation therapy. But I think this slide illustrates that quite well. This is a preclinical model. So this is a mouse model who are given tumors. And the wild type, or WT, is a normal mouse with an intact immune system. The nude mouse is a mouse without an intact immune system. And so here on this vertical axis, you can see tumor volume. So they're tracking how quickly the tumor grows. And on the x-axis, or the horizontal axis, you see days after radiation therapy. So in the wild-type mouse, when they implant the tumor, you can see that there's this exponential growth of the tumor. When you treat that tumor with radiation therapy, it blocks the tumor growth in a normal mouse. If you do the same experiment in the nude mouse, which does not have an intact immune system, you can see the tumor still grows exponentially, but then the radiation therapy doesn't stop it from growing. So there is definitely an importance to the immune system. It's a very complex field of research, but it's actually quite exciting in the radiation world. And from that exploration comes this idea of metastasis-directed therapy. I said that we typically will use radiation therapy in a palliative manner in patients who have metastatic disease, but there's a burgeoning interest in using it in a more aggressive manner, where we're going for ablation. So the idea is to wipe out these spots of metastases that can pop up around the body. These terms, oligometastatic, it basically, in general, the field's defined these limited metastatic disease as less than 5 sites. And the term oligometastatic just basically means a patient with 5 or fewer known metastases. The other setting would be a patient who has multiple metastases and they're doing well on their chemotherapy or immunotherapy, but there's one stubborn spot that's growing. And that would be considered an oligoprogressive patient because they just have one spot that's not responding to their treatments. And so there's an interest in using aggressive radiation to go after those spots. And the goal would be to impact, I put here, disease-free survival. There are other goals as well, but disease-free survival basically means a patient is living for longer without progression of their disease. There's a few scenarios that this could be employed. This MDT it represents metastasis-directed treatment or therapy. One option would be to try to treat every site of disease that we know about, and that would be an oligometastatic approach. A patient might have undergone a curative treatment and might have a recurrence that we could treat with metastasis-directed therapy. The patient might be actively on treatment and have a couple areas that are not responding or progressing, and that would be an oligoprogression. And then the more classic way we used to and still do use radiation therapy is to use metastasis-directed radiation for symptomatic disease with the goal of helping the symptoms. So I have a few slides just highlighting some of the early data that I think is quite exciting. So these are 3 of the studies. The first study is a study of patients who had prostate cancer that was oligometastatic. So in this study, it was 3 or fewer lesions. And these patients were randomly assigned to standard of care, which would be observation or their continued therapy, or receiving SBRT, that high-dose radiation therapy, to those known metastases. And the outcomes showed that those who received the radiation therapy had decreased progression at 6 months, so it went from 61% to 19%. And the big take-home from this early study, because it is a small study, is that there was no grade 3 toxicities, meaning it was rather safe. So there wasn't a lot of side effects by using this approach. The second study was a little bit bigger. It's still pretty small and it's early data. This was a variety of cancers with 5 or fewer sites of disease. These are patients who had either a partial response or stable disease on their systemic therapy, and they were randomly assigned to receive SBRT. They call it SABRE here. There's 2 acronyms just to make it confusing, but it's the same idea that we're using high doses of radiation to zap these spots. In this study, patients who received the high dose of radiation therapy had an improvement in median progression-free survival from 6 to 12 months, meaning they were living longer without progression of their disease. That was statistically significant. The overall survival, there was a trend. It was not meeting the threshold for statistical significance, but nevertheless, a trend that may suggest it's possible to impact survival using metastasis-directed therapy. The last study is called the Stomp Study. It's another study that was done in the prostate cancer population. Again, these patients had 3 or fewer sites of metastatic disease, and they were assigned to active surveillance or metastasis-directed radiation. And in this cohort, they looked at ADT-free survival. So to back up a little bit, in prostate cancer, part of what drives prostate cancer is testosterone. So hormone blockers or testosterone blockers, which we refer to as ADT, help treat the cancer and delay progression. It comes with a lot of side effects, however, that patients ideally would like to avoid. So this is another potential indication for metastasis-directed therapy, where we can zap these lesions, and it might mean that patients can avoid going on these medicines that have side effects for a longer period of time, which is a meaningful outcome. And so these patients had an improvement in their ADT-free survival, or they were able to go longer without receiving that hormonal therapy, hence longer without the ADT-related side effects. So there are burgeoning areas. We do SBRT here. We have SRS here, which is the high-dose radiation to the brain. We have liver-directed SBRT, and we have the same machines I used when I trained at Mayo Clinic. So we have the ability to do a lot of these techniques. And to switch gears, the talk was titled Navigating a Cancer Diagnosis, and part of treating a patient, a big part of treating a patient is coordinating their care, both within the patient and their family, and also within the complex medical community. And so radiation is just one part of cancer care that is often quite comprehensive and quite complex on the provider and patient side. So it often employs medical oncologists, surgeons, which can be ear, nose, and throat surgeons, neurosurgeons, thoracic surgeons. There's social work. There's dietitians that need to be on board to help get patients through treatments. And that's where the field of nurse navigators has become so critical. And so Caitlin's going to step up and talk a little bit about her role as a nurse navigator and the importance of that role.
Wow, that's a lot, right? So imagine being the patient and getting all of that information. So typically nurse navigators, and can you hear me okay with this? Okay. Typically, we as nurse navigators meet the patient at their first consultation here at the Cancer Center to establish care with them, to let them know, be an extra set of support for them. So as you can see, the complex medical system that they have to go through, as Dr. Roberts mentioned, there's all these different specialties that have to be part of cancer care. And so we're here to help kind of guide the patient through all of that. We're also very blessed that we are in New Hampshire, and so with that we have Boston to the south, we have Dartmouth to the west, and so with those academic centers we do share patients with because sometimes they do need to go outside of our organization for their complex surgeries and whatnot. So what do we do exactly? We serve as a single point of contact. So oftentimes when I'm meeting a patient and their families for the first time, I say to them, if you don't know who to call, you can call me. And I'll get you the answer, or I'll get you to the right person that can answer the question. We never want patients and their families to feel like they don't know who to call or that they're lost. And as you can imagine, the anxiety that comes with these diagnoses, it's really helpful just to have that one point of contact so they can reach out and have an easy answer and easy access. We listen to their fears, their concerns. We talk to them about what might be barriers to them going through the plan of care that's been set forth by their team so that we can figure out what can we do to make sure that you can get through this treatment and be successful, especially in those settings where the treatment is curative. We work very hard to expedite referrals, procedures, schedule them for their necessary tests so that we can start treatment as soon as possible. Because if you can imagine, as we're working patients up, they might know they have cancer, but the anticipation of starting treatment is a big deal for them, right? So we want to get them started as quickly as possible and as safely as possible, knowing that we've gone through everything as part of their workup. We communicate with the outside facilities that we share and coordinate care with. We do attend tumor boards, which is a multidisciplinary clinic here at Concord Hospital, where a radiation oncologist, a medical oncologist, pathology, radiology, the surgical team for whatever disease site, we all come together and talk about the patient's plan for those really complex patients. And from that, care recommendations are made. So we, as navigators, attend those meetings, transcribe all the discussions, and follow up on those recommendations. And then we help connect patients to community resources. So that might be right here within the Payson Center to our dietitian and our social work team, but it might be outside of the Payson Center here to outside community services. If the patient comes in and they're homeless, they need housing, they need help with their insurance, they don't have insurance, all those sorts of things. We work on process improvement projects and community outreach just to kind of get the message out there about the work that we're doing here at the hospital. So this is a really nice model about oncology nurse navigation. It actually comes from the Oncology Nursing Society, which really recognizes nurse navigation as a vital part of cancer care. And so what we really like about this is, first and foremost, we are working to assess and address the barriers to patient care. We're providing education, those resources, referrals, but really what it highlights is that we work with patients not just at diagnosis, but for prevention, for screening at diagnosis, but also all the way through into survivorship. So when they're done with treatment, what happens, right? Usually they spend a lot of time here. They might be coming in 5 days a week for 7 weeks for radiation. They're really tied in. But then what happens at the end of all of that when they just go off and it says, oh yeah, we'll see you back, in a week or two, but they've been coming in daily, right? So it kind of feels like you fall off the edge of a cliff there. So just making sure that us as navigators are still tying back into those patients and making sure that they don't feel like they're lost after they've been followed so closely. And then another piece that's really important for nurse navigators is to ensure that patients and their family members have thought about advanced care planning, which is making sure that if something were to happen, cancer diagnosis aside, if you weren't able to make your own decisions, do you know who would make those decisions for you? And do you have that in writing? So these are conversations we have with patients, and then we can refer them to our social work team to get those advanced directives completed. So that, if they end up in the hospital and they can't speak for themselves, we know who we can talk to and what their wishes would be. So I'm going to go over a case study of a patient that I worked with. This was a 54-year-old male patient who had had painful swallowing for about a year. He had been seen by his PCP who thought he maybe had an infection and treated him for that, but it didn't go away. So he was evaluated, he was sent to ear, nose, and throat. That's the otolaryngologist. I think we had a talk by one of them recently. And he was found to have a cancer of the right tonsillar fossa. It was HPV positive, and so in head and neck cancers, it's really interesting to note, most head and neck cancers historically were caused by smoking and drinking. But more recently, most head and neck cancers are caused by the human papillomavirus, or HPV. What's great about that is that it is a much more curable cancer. So there's studies, and Dr. Roberts could speak to it if you wanted to, but there's studies down the line. They're working on figuring out if we need to treat patients at the same level that we normally do in terms of their chemotherapy and radiation protocols. But so he had HPV positive cancer, which is good. But what the other thing he had was a finding in his right middle lobe in his lung. So what we were trying to figure out at the start when we first met him during his workup was, does he have a head and neck cancer and a lung cancer? Or does he have a head and neck cancer that spread to his lungs? Because head and neck cancers do like to metastasize to the lungs. So we were working to try to figure that out for him. So the next slide is just going to go through kind of all the different times or touches that I had as a navigator for this patient. So I received a referral from the ear, nose, and throat, or the otolaryngologist on this patient, to start doing some pre-work for dental extractions. For head and neck patients, it's really important if they have teeth that might need to be extracted, that those are addressed prior to radiation, because the radiation weakens the jawbone, and it can lead to infections and destruction of the jawbone, which can be very hard for the patient, and then they ultimately have to sometimes go to hyperbaric oxygen therapy to treat the complications that come from that. So we want to make sure, part of my role is to find out, do you need dental extractions? And how are we going to get that done? Do you already have a dentist? Do you not? And how are we going to get you to the dentist and get that workup done? So I got that referral. 8 days later, I met this patient in person at the time of the radiation oncology consult. And he was already referred to an oral surgeon at that point, but his appointment was way far out. So I was able to expedite that by 20 days. He was followed by pulmonary, right, for that lung finding. So I was able to expedite his appointment with them by 8 days. And then he was found, when he went to the oral surgeon, that he needed multiple dental extractions. And originally they said, oh, we're booking out a few months at least, which obviously, we want to get his cancer treatment started, so that wasn't okay. And I was able to coordinate that surgical date for about 3 weeks later. Subsequently, he had a COPD exacerbation, which ended up causing the cancellation of a couple different procedures that he needed. So I requested that pulmonary see him for an acute visit to see if we could kind of overcome his COPD exacerbation to figure out how we could get those procedures to remain as scheduled. And then he was going to an academic center to see if he could have surgery. And with that, they had booked or rescheduled his laryngoscopy, which is a scope down the throat. They had booked it out knowing that he had that COPD exacerbation. So I did get that expedited by 12 days after the pulmonologist had seen him. So this patient had to go undergo a bronchoscopy, which is also down the airway, but it goes in to look at that lung nodule spot. And that was through endobronchial ultrasound, which is what the acronym EBIS stands for. The results from that returned non-diagnostic, meaning we didn't get any tissue from it that could tell us whether or not that was a cancer. So that day, it just so happened that both of the pulmonologists that knew this gentleman were not in the office. So I was able to track down his radiation oncologist, who was not Dr. Roberts, but one of them, and we got an order so that we could send him to a different care team to access that nodule via a needle through a lung biopsy. Got that referral over there, and then I ended up having to expedite that by about 8 days. I also worked with this patient because he didn't have insurance, so we did get him set up with the Concord Hospital Financial Assistance, which was able to cover his care and the cost of his care. And then his dental extractions altogether came to almost $4,000, which he did not have the money for, right? So because Concord Hospital is a philanthropic organization, they were able to cover the entire cost of his dental extractions for this gentleman. And then he successfully underwent chemotherapy and radiation treatment. Within a month of his initial diagnosis, he is doing great. He's survived it, and he is back to work and thriving. So that's just a couple examples of the points of contact that we had with him that made a difference in expediting his care. And this is some of his plan.
So I'll just step in, and this is an example of his plan. And it just gives a little sense of something called dose painting with the technology we have these days. You can see the heat map of the radiation therapy. And this down here would be a positive lymph node. So we can simultaneously deliver more dose to that little spot while we're delivering a more uniform dose to the other areas that are not known to be involved but are at risk for being involved.
And the last thing I would like to say is just, as you can see on this, there's a number of very critical structures within the head and neck. So you can see, the spine, the orbits are up here, the jawbone. So if you can imagine how difficult that plan is to make for a head and neck cancer patient. So now I'm going to turn it over to Kim Pauliks, who's going to talk a little bit about a case study for a lung cancer patient.
All right, so we're gonna switch gears here a little bit to a lung cancer patient. So this is a 52-year-old female who presented with low volume hemoptysis. What that means is coughing up blood. She was found to have a large mass in her right middle lobe with hilar and mediastinal nodes. That means lymph nodes that are positive in the center of the chest. Her pulmonologist performed a bronchoscopy with EBIS, as Caitlin explained, an endobronchial ultrasound to be able to get tissue from the area. She was found to have a non-small cell carcinoma of lung primary. Normally we can distinguish between two different subtypes of non-small cell, but we were unable to in her case the way the pathology was staining. So she, when I met her, was an active smoker for many years. She had no primary care, so no routine follow-up or preventative care, and she actually was uninsured, which is why she didn't go to the doctor. So she had multiple staging studies. What that means is multiple scans of her body, and she ended up having a solitary brain met. That means her primary lung cancer had actually metastasized to her brain. So we used a multidisciplinary team approach to treat these multiple areas, which we'll be able to see in the study that kind of didn't line up the way the typical case actually does. So first, I obtained a navigation referral by attending our thoracic tumor board. And as Caitlin kind of explained, thoracic tumor board is a weekly meeting with a multidisciplinary team to review complex cases. So this includes our pulmonologist, a thoracic surgeon, a medical oncologist, a radiation oncologist, a radiologist, a pathologist, and our tumor registry. So I do transcribe these notes for thoracic tumor board, and so that's how I was able to find this patient manually and put her on my panel. So I met her at her radiation oncology consultation where I assessed multiple needs, including kind of what I covered in the last slide of her being uninsured and still smoking. So I was able to connect her to our Concord Hospital financial assistance team. We were able to help her with her application for Medicaid so she could be insured. And the benefit of that is Medicaid can be retroed. So all of these scans and workup that she had, she was pretty concerned about the cost of that, but that was all retroed and actually covered for her once we got the process going. So part of what I said previously is she had a solitary brain metastasis. So what that meant is that I was in touch with the radiation oncologist, and we needed to expedite a neurosurgery referral to see if we could actually remove this versus doing SRS to her brain. So I was able to expedite that. In the meantime, I service connected her to a primary care. What that means is that we essentially here at Concord Hospital will assign her to somebody. So she was assigned to Hillsborough family, and I was able to move up her appointment to be seen because she hadn't seen a doctor in quite a number of years for being uninsured, and so we wanted to make sure her routine preventative workup continued while we were moving through her cancer diagnosis. So I was able to join her at her medical oncology consultation, where we were able to continue to talk about her multiple barriers. So part of planning, which Dr. Roberts can get a little bit more into later, is patients with brain metastasis who are going to have stereotactic radiosurgery performed actually need an Srs Brain Mri. And this is a specific brain MRI that offers thin slices of the images, so the radiation oncologist can do their planning. So she then had her single SRS to the left cerebellum, which was the area of her metastasis. And Dr. Roberts is going to speak a little bit about what that planning actually entails. Just like this.
So we did get the thin slice MRI, and I don't know if you can appreciate, but there's a small single metastasis in the cerebellum here. So we generated a stereotactic radiosurgery plan for her, which would be delivered in just a single treatment. And these are various ways to look at the scan, but essentially this is the prescription dose targeting that area, and we were able to deliver that in a single treatment without complication. And so this is kind of similar to the approach for the metastasis-directed therapy, where we're aggressively treating that single brain metastasis. And with a patient like this, who's young and otherwise been healthy, you know, in years past, one could argue, well, if the patient has metastatic disease and we can't cure this patient, and so we need to really balance out how aggressive to be. But with the technology we have these days in several types of cancers, if the metastatic disease is very limited, we still move forward with aggressive treatment. Many patients want to do that, and now we have the ability to do that. So the plan was to do a standard course to the lung, which is 6 weeks of chemotherapy and radiation therapy together, delivered 5 days a week. And we worked hard to generate a plan, and it may be a little bit difficult to appreciate, but essentially she had too much disease to treat safely from a radiation perspective. So we were unable to meet the lung numbers safely. So when that happens, we switch gears to move forward with a different approach where we can start with the chemotherapy with the goal of shrinking the tumor and shrinking the target volumes to the point that it's safe to come back aggressively with chemotherapy and radiation. So though we planned to move forward with the 6-week conventional course of treatment, we had to switch gears for her.
All right, so I'll hop back on here and explain kind of where that actually brought her. So as Dr. Roberts said, our radiation field was too large to safely move forward with definitive chemoradiation at that time. So where do we go from here? While we were figuring out that plan, she was able to see her PCP and actually get a good amount of preventative care taken care of while we were developing a plan for her. So she was able to have her pap smear, a mammogram, a Cologuard to look for colon cancer, labs that she has not had in many years, and we were able to get her to quit smoking. So because her radiation field was too large, I had reconnected her to our medical oncology team, knowing that we were going to need to do induction chemotherapy to hopefully make her disease a little bit smaller so those radiation fields would be more appropriate. So the decision was made for her to get 2 cycles of induction chemotherapy, and that was with carboplatin and Taxol. So those are full dose chemotherapies that she got, 1 dose, a 3-week break, and then another dose after that. So unfortunately, there has been some delays, and because she's kind of had these bumps in her road, I was able to expedite her chemotherapy start. And part of what I did was coordinating what we call a teach and treat. So at New Hampshire Oncology, we will set a patient up for a 1-hour teaching session where they get to hear, everything the medical oncologist spoke about again in terms of the regimen of her chemotherapy, the side effects, the pre-medications, how to contact people when they need them. So we were able to avoid that additional teaching session, and I was able to speak to the clinical leader at New Hampshire Oncology, and we did her teaching session and her first day of chemotherapy on the same day in order to expedite getting the chemotherapy going. So she did need some help with side effect management, so that's another thing that Caitlin and I will help with, kind of the coordination piece of things. But when patients are actually on treatment, there's a lot of different side effects that come up. They may be chemotherapy related, they may be radiation related, and we can kind of help direct the patient to which team needs to address those side effects. A lot of her side effects were constipation, and we'll kind of go in a little bit later about a bowel regimen that we were able to get going to help patients with constipation during their treatment. So unfortunately, this patient went through induction chemotherapy, and her CAT scan of her chest showed that her disease was actually larger. So what that meant was that we would not have a role for radiation again for her. As I'm sure you can expect, she was very emotional about this. I offered a lot of support to her. She really had her heart set on starting chemo and radiation, but we just had to move direction, and I gave her a little bit of hope that we're going to talk about a new plan. So how are we going to do that? Her medical oncologist consulted a tertiary care center in Boston to find out what's out there, right? This is a young, healthy woman with a difficult path. She again was able to have a teach and treat like I spoke to you about earlier. And that was for a double immune therapy, which is what the Boston provider had recommended for us to do. So she started her double immune therapy and ended up testing positive for COVID-19. What that created was an additional delay because with our policies that are in place, she needed to stay out of the oncology office for 10 days. She luckily was not very symptomatic, meaning she did not land in the hospital. She was able to treat this at home. She did not need antibody treatment. She did well. So she was able to get back on her treatment after her 10 days out of the office. So once she finished the immune therapy, I was able to coordinate another CAT scan of her chest and to have the radiation oncologist follow up on, are we at a point that we can now safely give her chemo and radiation together? We were. So she was able to complete definitive chemoradiation, which included 30 fractions of radiation, which is about 6 weeks, where she came in every day to get that. In addition, she received 2 cycles of cisplatin etoposide, which is not an easy regimen, but she was able to do it. We currently have her back on her double immune therapy, which is what we had done to get her to be able to get chemoradiation. And so she's on nivolumab and ipilimumab to this day. She is doing well. She continues her maintenance. She is not smoking. She follows up routinely with her primary care. And she obviously has insurance, which I told you about. And so she's in a really good place with her cancer and is doing well on her maintenance immune therapy. So we're going to switch gears a little bit and talk about what the Hope Resource Center offers in terms of support. Here are all the locations that you may see Caitlin and I supporting patients. We kind of will travel anywhere that a patient needs us. So we are obviously present in the specialty offices like New Hampshire Oncology, Radiation Oncology, Caitlin for ear, nose, and throat, myself for pulmonary and thoracic surgery. We will attend consults in all different areas of the care team to really be a second set of ears and make sure we can reinforce the plan with the patient. Other places that you'll see us is day surgery. You know, Caitlin will go over there and do tube feeding, teaches for her patients that are getting tube feeds, pre-op testing. In hospital, if one of our patients is admitted, we will join them over there. Hospice house if somebody's at end of life, or a rehab center, and home visits with palliative care. So the Hope Resource Center has a whole team of support, so not just Caitlin and I supporting our cancer patients. We have 3 social workers, Nancy, Judy, and Jackie, and there's a lot of crossover between that. So a lot of times Caitlin and I are actually meeting these patients, assessing the barrier. And that could be that their barrier is that they don't have advanced directives yet, or they don't have a way to get to their appointments. They need help with transportation to get here. Or they need some additional financial support. We help with gas, we help with groceries, we have grants. There's so many things that we can do to help these patients. So a lot of times Caitlin and I will assess those barriers and kind of tie them into the resource that they need to for additional support, and that includes our social work team. We have one oncology dietitian on staff. Her name's Megan. Again, a lot of times Caitlin and I will assess a patient who's malnourished, who has lost a lot of weight with their cancer diagnosis, is having difficulties swallowing. A lot of Caitlin's head and neck patients have a lot of trouble swallowing. They may or may not have a tube feed, and so Megan can help support us in that way. We have mastectomy fitters, we have a wig bank, we have a boutique that offers lots of different cancer products that people can actually purchase. We have support groups, educational classes. A lot of that's done virtually with the pandemic. We also have complementary therapies like guided imagery, which we actually do over the phone with all of our COVID-19 precautions, Reiki, acupuncture, aromatherapy. So we're going to move a little bit into process improvement, which Caitlin and I will kind of share talking about.
Do you want to do ERAS first?
Yeah. So the second bullet down, you're going to see enhanced recovery after surgery, or acronym ERAS implementation. So ERAS is a modified protocol where we were able to provide nutritional beverages to the thoracic surgery office. This protocol included surgical lung cancer patients. So this allowed them to drink these nutritional drinks preoperatively, and there's kind of some criteria on who gets what drinks and how much they're drinking. If they're screened high risk for malnutrition, they automatically get a referral to our oncology dietitian before they've even hit here in the cancer center. The ERAS protocol, what we're seeing is that it improves surgical recovery, and what that means is decreased length of stay in the hospital. A lot of these lungs come out of the operating room with multiple chest tubes and are in the hospital for 5 days plus. We're seeing that length of stay drop down. They have quicker return of their bowel function and fewer post-op infections. So it's been a really good project. We've implemented it in lots of different offices, but specifically for surgical lung cancers, we've been able to do that. I'm going to switch it over to Caitlin.
All right, so I'm going to talk a little bit more about dental barriers. So I follow the head and neck population, and we talked a little bit earlier about how focusing on dental problems and making sure that these teeth that need to be extracted are being removed prior to radiation is super important. So when I first started in the navigation role 5 years ago, I went and I shadowed a bunch of different parts of the team. And I remember to this day, I went and I said to one of the ENT doctors, "What do you want from this role?" And he said, "Please fix the dental problem." And meaning we can't get these patients' teeth treated before they start. And then he's seeing these patients afterwards for surveillance, and he can't, their teeth are breaking, they have all these issues. So with that, the cancer committee here at Concord Hospital decided that it was going to be a focus in the year 2021 as an initiative. So we brought together a small subgroup of us to work on the barriers to care. And what we came up with was we partnered with the New Hampshire Dental Society, sent out communication to all the New Hampshire dentists and said, who's interested in helping our oncology patients? And from that, we got about 7 dentists who were really invested in our patient population and who were willing to ensure access, meaning we call them and we say we have this patient, and they get that patient in under a week for an evaluation and get them set up for any extractions or necessary cosmetic work that they need. And with that too, Concord Hospital did put through a grant for these patients so that we could pay for the cost of that care for them as well. So just a couple things in terms of addressing dental barriers that we did. It's been really successful. This is a small population of patients. Our head and neck population, we get about 40 head and neck patients a year. And of that, this year, I've helped about 6 patients with this process. So as you can imagine, the cost of dental care is not cheap, so it's been very helpful for them. And then the other thing that we touched on earlier was our Constipation Initiative. You know, when patients have cancer, they often have issues with constipation, and that can be related to pain medication that we're giving them, right? So they may never have needed to be on pain medication prior, but their cancer is painful and the treatment we're giving them is also painful. So some of these patients end up constipated as a result. And so we identified this as a problem, and we created a standardized education for these patients so that we could prevent that issue. Which has been working very well, and patients are much happier. So, you know, with this role, I think one thing to highlight is that we see a lot of trends, right? We see a lot of common themes as navigators because we're looking at the big picture. So we can identify gaps in care and ways that we can enhance our care. And that's how we are working to enhance clinical pathways and overall patient care each day. So how do we do this work? We are very, very blessed that Concord Hospital has Pedaling for Payson, which largely underwrites our positions. The Pedaling for Payson event is coming up. It is September 10th. And we have mountain bike rides, gravel rides, or road bike rides. And you know what? If you say, hey, I'm not a bicyclist, neither was I. My first year doing this about 5 years ago, I bought a bike the week before the event. I went out. I basically died because I was in the wrong gear. And then the next week I did 16 miles. So if I can do it, you can too. And Kim has a funny story.
So my first year, I didn't even have a bike. And so I borrowed a bike from our dietitian, and I did all 16 miles. So you guys can do it too.
So just concluding, I can't emphasize enough how important the work is that the nurse navigators do, primarily to help these patients get expedited care, coordinate all the complexities. I'm sure you can appreciate it, having gone through those 2 patient experiences. There would be otherwise a number of delays and compromised care without them in that role. I also hope I was able to give you some background and insight into the role of radiation therapy and the continued advances in cancer care. I think technology and innovation really have been at the heart of our ability to advance the radiation techniques that we use today. Again, cancer care is increasingly complex, both from the provider side as well as the patient side. And I didn't get, my area of expertise is not the medical oncology realm, but that realm has equally become complicated with all these new drugs coming out and the different immunotherapeutics. And certainly the oncology nurse navigators play key roles in coordinating care across their cancer trajectory for every patient that they're hooked up with. And that these new navigation roles, they continue to evolve. There are unmet needs in some patient populations, so the Pedaling for Payson is a great opportunity to help support these nurse navigators. And I wanted to just acknowledge Lisa Kennedy Sheldon, who generously shared her slides in some of the nurse navigation realm. So thank you for joining and for your attention, and I'm happy to take any questions. Yes?
The higher dose, I'm going to call it radiation seeds, I'm not sure that that's correct, but anyway, Do the patients have to stay in the hospital then? And are they removed afterwards or what?
So the high dose radiation is it's often delivered as an outpatient procedure. There are times we would keep patients. We don't do the high dose radiation here. They do it in Manchester, at Wentworth Douglas, down in Boston. We do have the seeds, and that's specifically for prostate. So the high dose rate is not any more toxic for the patient. It's on the planning side, it's a little bit more advanced in the ability to shape the dose to some extent, because you first place all the catheters that you need, and then you can use these computer programs to design the delivery, and then the robot essentially will send that radiation source in and park it in this position for 5 seconds, back up 3 millimeters and park it there for 6 seconds, and so it can deliver a very specific plan.
Okay, I think I have a question. I do want to, I know that Caitlin, you are head and neck, and you have, and then Kim, you take care of lung. Are there other navigators that handle other types of cancer? You want to just comment on that? I'm sure those are tuning in.
Yeah, so right now here at Concord, we only cover the disease sites of head and neck, esophageal, and lung, because I also cover esophageal patients. We do have the breast care center, which has breast navigators, but there are nurse practitioners over there. So really, we would love to develop our program and make it so that other disease sites can be a focus as well. But no, we do have primary care nurse navigators. So sometimes if there's a patient who would be a good navigation fit, but maybe not a disease site we could follow, we might tie them into their nurse navigator at our Concord Hospital Medical Group office to try to support them that way. But absolutely, no, we would love to have more of us that could cover more of those disease sites, because there's definitely unmet needs. Yeah.
Perfect.
Thank you.
Do they have nurse navigators in the Dr. Pelosi school?
They do. We have a urology nurse navigator who follows a very specific oncology population. So there is a navigator over there that falls under our navigation program, but she's not here at the Payson Center, so she doesn't fall in with me and Kim as much. But
She's not in the Payson Center.
she's not. She's over at the Center for Urologic Care. Yep. Good question.
Thank you so much, Dr.
you.
Roberts, Caitlin, and Kim, for an absolutely fascinating presentation. Learned so much, and yeah, very, very interesting. And we're very proud. We're very proud of all of you and the services that you provide to patients at the Payson Center. And Concord Hospital Trust is very proud to support the nurse navigation program through Pedaling for Payson. And I would say that if you don't want a bike, you can certainly support Caitlin and her team. You can go to the Trust website and click your way through to learn how to do that. And certainly to come out on that Saturday and cheer the team on would also be very much appreciated. So we look forward to supporting and having a great Pedaling for Payson year for you as well. So our thanks to everyone for joining us today for What's Up Doc. Hope you have enjoyed the program. Next month on Friday, September 9th, What's Up Doc will welcome Dr. Ryan Van Hoff from the Cardiovascular Institute. And Dr. Van Hoff's topic is going to be understanding heart disease and your risks and what you can do about it. So we hope you will join you then. Continue to be safe and stay healthy and have a great rest of your summer, and we'll see you next month.